Hey everyone, welcome to EM Grand Rounds. I'm Britt Guest.
And I'm Scott Kobner.
Welcome. We have a jam-packed show for you tonight. Couple updates and things that we've been doing as the EMRAP team. Recently, as in of Monday, we just got back from Kenya. We were there with the EMRAP Go. That's the global outreach part of EMRAP. We went working there. We went to 2 different hospitals. We worked with the Aga Khan diploma team, did a whole sim day there, which was really amazing. And then we did a whole procedure workshop. You see Mel and Pablo there with goat tracheas doing crikes. We did pediatric intubations. You see a baby doll there with IOs. We did it all. It was super amazing, and it was really just awesome to finally be back in Kenya since COVID.
Yeah, and you just got back. You're like in the middle of the jet lag right now, right?
It is the middle of the night for me right now, to be completely honest. But I'm here, and I'm ready to rock.
It's like half the people in between night shifts. So you guys are on the same...
Yeah, I mean, that's what really night shift, jet lag, it's pretty much the same thing.
Basically the same thing.
All right, so who do we have with us tonight?
We have an all-star cast of characters and faculty. I'll let you decide who is who. With us tonight, we've of course got Sarah Krager, we've got Jan Schoenberg, we've got Billy Mallon in the house. And we might have a Stuart Squadron, skulking around somewhere.
He always kind of just hides in the studio somewhere. Yeah. You'll find him in some closet somewhere. There's Stuart.
So it'll be great. Really looking forward to it. And again, this is our EM Grand Rounds. We do urgent care Grand Rounds every other month. Feel free to, in the doobly-doo down below, you can subscribe, like, comment, and you'll never miss out on ones that we do. Our next one is coming out in June 6th. And that'll be urgent care. So don't miss them. And you can sign up for mailing letter for more updates on them too down below. But enough of the how
I want to hear these people talk.
Yeah, exactly.
The faculty that we have tonight is too amazing. So let's move on to our first segment of the evening, which is clinical images.
It was all a dream. It was all a dream.
All right, time for some clinical images. Contrary to what the bumper suggests, none of these are hand-painted by me, those beautiful artwork. You guys ready to go through some fun stuff? Some interesting cases?
Yeah.
All right, let's rock and roll. So our first one, we have an 18-year-old guy. He's on the 16th hole of a golf course. There was a terrible lightning storm, but he was so far under par, had to keep going. Lightning struck, and he was found like this. What do you guys think's going on with this new rash that he comes in with?
Well, as a golfer, I can understand why he kept going. And I think that this looks like a lightning injury. And the reason I know that is just because I studied for boards. It's not like we see this every day, but it's the kind of thing that you kind of sticks with you. It's very, very unique, this pattern. This fern, it's a fern. I mean, it's a beautiful fern. It's not a tattoo.
I thought you were going to say, it looks like artwork, though. I mean, I thought maybe this was like a tattoo removal situation. Right. I don't know. But this is, I think, the way that you most frequently encounter it is on your board exam or something like that, right?
Yes.
And I guess it's because it's important because it's a clue to a found down patient, right? Because if these patients will be found down, unconscious, who knows what happened, and this might be your only clue. So it's like one of those pathognomonic things. But Billy, it's
and key.
Yeah.
They're found down. Their pupils are often non-reactive.
Right.
But they're with it.
Right.
So that's typical of lightning strikes. Not all lightning strikes have this by any stretch, and they can be pretty bizarre. That's a pretty nice one. I've only seen 2 or 3 in my whole career. I think I've seen more on board exams. I've seen.
We didn't even say the name. Isn't it called Lichtenberg
figure?
Yeah. That's the best part about it.
A Lichtenberg figure.
Yeah, so it's pathognomonic, doesn't happen all the time, and there's no treat, and you don't need to do anything if you see. It's not like it doesn't require any specific treatment, and it doesn't mean anything in terms of like vascular or neurologic. It doesn't follow. It's just a dermal thing, right? And I don't remember mechanisms.
It's one of
like
these
a steaming
things,
or something.
And there's so many things that lightning can do. When even 3 weeks later, you can develop a stutter, for example, or weird neurologic things. Yeah. And what you were is hit by lightning, and the listing of all the things that can happen to you when you get hit by lightning, some people are fine and some people have bizarre complications.
Yeah.
Yeah, it's a really weird mechanism. It's actually like the dilation of the blood vessels on the skin, and then the red blood vessels extravasate in this weird pattern, following that. It's like the flash over effect of these electrons that send it out. And so it can last up for a few hours. Some people can last longer than that to have it, but some people describe it as looking like a henna tattoo. I've never seen one in real life.
I was going to say henna. I was going to say henna.
It does look like henna.
Yeah.
But this is all. The other thing I feel like it comes up on boards is that this is like the MCI where you actually want to resuscitate the person that is pulseless, the person that was struck by lightning, because like this is a great review paper that ROSC in these cases is actually the rule, not the exception, if they get timely CPR, and so that's where a lot of times it comes up. I've never seen
and you got to remember that if they look neurologically out, it's still worth doing.
Yes, that's right. It's sort of reverse triage because some of they stop breathing, so you want to breathe for them. Most of those people would be a black tag in any kind of regular MCI, but this is a case where you actually would try to.
Just remember, it breaks the rules. Yeah. Exactly.
It's crazy. Not that many people get struck per year, but the statistics are higher than you'd expect. And this one paper, it is funny. It's like myths about lightning. It's like it can strike twice in the same place. Like, thank you. That was helpful. In this peer-reviewed publication.
What's the golfer's name? Lee Trevino.
Lee Trevino. Yeah.
Hit 3 times.
Yeah, right.
And the typical golfing joke is he was using a 2-iron because even God can't hit a 2-iron.
I just started with the golf bit because I was on my mind. There it goes. Comes around. I love it. That's amazing. All right. Are you ready for our next image?
Yes.
Yeah.
All right. So we have this gentleman that was unfortunately in a really bad car accident. You know, during the primary survey, this is what you see going on. He's breathing.
You know, for the first few seconds when I'm looking at this, I thought, I see a guy in the C-spine collar, and I see this kind of like seesawing paradoxical motion. I'm like, oh, it's a broken neck, right? It's a C-spine fracture, and he's abdominal breathing. And I'm like, no, it's not. It's not the belly. It's actually in the chest, and it's not. It's localized. It's just on that
It's
left
like
side.
He
it's a
broke
it's not
his
moving.
sternum.
Yeah.
And ribs away from each other.
Yeah.
All of them.
So this is a flail chest.
True flail and bilateral flail, and he'll breathe for a little while, but you need to get ready to tube him. So he needs a quick resus because it's probably worth getting a little bump in his vital signs.
Yeah.
But you better get ready to tube him
Show us
soon.
the clip. Can you
we
go back?
could definitely go back.
Again?
Yeah, let's go back and
Because just to get an idea of the enormous pressure that's happening each time that segment gets sucked in. And it's like, how do you overcome that? Well, you overcome that with positive pressure ventilation. There's no real way around
Or,
it. You know?
no, if it's one side, you can overcome it with sandbags and pressure and other things.
What do you think? You gonna sandbag that?
No, no way.
You gonna sandbag me?
I'll sandbag you.
Yeah, I know you will. I know you will.
Yeah, I mean, I think there's not much more to be said about the flail chest that, you know, and I think there can be, I've seen smaller ones where it's a smaller section of rib, and it can be kind of subtle. Like you have to actually, you know, it's like, I kind of on my trauma assessment, stand at the foot of the bed after we've wrapped up the primary surgery and just like looking at the chest. Yes. And get
Look
that
at the
view.
horizon of the chest.
And sometimes you can even get that subtle pneumo in there. You can see the one side rising. It's been a really helpful trick that I've certainly learned. But yeah, this one was pretty obvious. It'd be hard to miss this one.
And and I take it, he did get tubed.
Yes. Yeah, that would be the outcome for him. All right, last image. You got a patient who is found on the street coming in. You don't have much other history, but you see this hand rash. You see that there's a rash all over the rest of the body too. But this particular picture of the hands really like exemplifies what that rash looks like.
Are you going to say it or am I going to say it, Billy? Got caught red-handed? Is that what you're going to say?
So there are lots of things that can, you know, ichthyosis, psoriasis, but there's something about the between the fingers nature of this that should begin to make you think of something. And we used to see a lot of this at County, and the reason we used to see it at County was because we were the last leprosy clinic in the world. Not in the world, in the United States. And the last leprosy clinic, the reason that's important is because leprosy affects your ulnar nerve and so you get this neuropathy and you're at high risk for this diagnosis, which is scabies.
That's really
Crusted
interesting. Yeah,
scabies.
crusted scabies.
Sometimes called Norwegian scabies. I think more commonly referred to now as crusted.
Not if you talk to them, it's not. Yeah. they don't like that.
So it's a big deal. And the other reason I get passionate about this one is because so many people in the emergency room get reamed over this. So a patient comes in, they're fucking sick as shit. You're doing your stuff. They're non-catotic, hyperosmolar, You're doing all that. They're intubated, and you call Derm, afterwards. And Derm's like, well, it's too much for me. I'll see you later. And then they go up, and 4 days later, they figure out that this person's got crusted scabies. And now they have to shut down the ICU because it's all contaminated with bugs and fecal balls. And they're looking for someone to blame, us, as always. And I finally learned how to fix that. And the way you fix that complaint is to say, wow. And how did the diagnosis get made? Well, the dermatologist did the scraping say, yeah, bet. You called the dermatologist? Then that's when you know, and they look around. Well, the dermatologist came. No, I called the dermatologist. I made the diagnosis, and you didn't get it done quickly.
Well, there are some. Thank you. There's some things that actually people need to know, and there's some big misperceptions about crusted scabies. So, for example, when I never saw a case until I came to LA County.
We see a bunch.
I never seen, and I've seen tons of scabies in Canada. Tons. It's very common in where I was working in Canada. But I missed it because the patient wasn't itchy. And so this is an important distinction we need to talk about.
Go ahead.
Well, no, I mean, the patients were, like, in crusted scabies, the patients are immunocompromised, most commonly HIV, in my experience.
Not always, though.
But that's what it was. That's sort of and that's how you sometimes make the diagnosis, actually. You come in with this. Yeah. But it also differs in that these crusts, they have millions and millions of parasites on them. It's not like most people have thousands and thousands. It's the count of these organisms is huge.
Yeah.
And they don't typically get it where scabies isn't usually above the neck. Crusted scabies is. Mm-hmm. And so that's why I missed it. I saw a guy with these big crust. I thought it was sort of a primary derm condition, that it was something like that. So anyway, those are the main things.
So there's some other reasons why it doesn't itch. Many of the patients who have it, there are the HIV ones. But of the other side, and I mentioned already Hansen's disease, there is those with peripheral neuropathy. And it is peripheral neuropathy across the whole spectrum. No one has seen, I've seen probably 10 cases. So no one's really seen like hundreds of cases, but I've seen a bunch. And many of them don't know what it is because they have a neuropathy.
Yeah, but I think the overwhelming reason is that they don't have the immune response. The itching's from the immune response.
Right. Yeah.
So if you don't have that, and so there's probably a number of conditions that you could be onto by the fact that they don't have that immune response, and they have that. And the other thing is it's serious. Yeah. Like, I mean, you can get a super infection and die of this, and so they need to get aggressive treatment, including the parenteral treatment.
And topical doesn't work. Yeah. So you could try topical, but you're just putting the topical medicine on mounds and mounds of scabies,
of sort of
feces, pill balls, etc.
Yeah.
You have to give them ivermectin.
Yeah.
Here's some other pictures of it really showing the extent that you can have.
Yeah.
And I think it's interesting, like one of the first case reports actually was a patient that they thought had bad plaque psoriasis. Like, well, we just got to give more immunosuppressants. Certainly compounded the problem for that person. This is something it could also be easily confused with. And to your point about treatment, absolutely right. You can't just walk away with doing like a permethrin every little while. You're going to have ivermectin making a comeback for the good guys actually here, what it's supposed to be used for at a pretty high dose. It's got a weird dosing regimen because it's like every other few days, but you need that on top of doing the permethrin.
I said parenteral, but I meant systemic, right?
Yeah.
Yeah. I don't know if there's a parenteral treatment, although probably Sean Nort is, as we speak, typing in right now exactly what the parenteral treatment is. But.
And then we have our final image, our mystery image, to see if anyone out there in the chat can guess what this is. This is somebody who's coming in for a weird thing that appeared in their eye. It's not painful. They have otherwise intact vision, but this is the image that you see when you look under the slit lamp.
And most clinicians would say, the film's just loaded backwards. It's upside down.
Yeah, this is not
Well,
upside down.
this shows you how cruel you really are. You made the patient stand on their head for how long before this? This is what is this, like a reverse triple hypopian? What is it? Inverse?
It's an inverted hypopion.
Backwards hypopian?
We use the tilt table for one thing.
I have no
here.
idea.
That's what
I
we
have
do.
no idea what that is.
And
It's
he's at the wedge
surgical,
eardectomy,
post-surgical,
obviously.
post-surgical.
Basically, what it is, if another way to think of it, is it's like a walled-off empyema in the eye.
Okay.
It's in the.
Put an eye tube in that and get that drained.
This one's in the upper eye.
Eye tube.
I'd
What
love
is
to
it?
hear
What is it? Is it?
We're gonna give the final answer at the end.
Is it
we're gonna
pus?
give it.
Oh, at the
yeah.
end.
Oh, okay.
At the end, we're gonna give the final. Those are
All right.
all great. I was gonna keep my lips sealed on this one. If you guys in the chat, what else do you think? It'll be interesting to see, and we'll talk about it at the end. Something to percolate on. But now we have our next segment. We're gonna talk about to tube or not to tube.
To tube or not to tube? That is the question.
All right. To tube or not to tube? That is the question. That is the discussion that we are going to embark on next. So I know there is a poll in the chat. It would be really awesome to see if you guys would intubate or not intubate these patients as we discuss here as a group. So as your moderator, I'm going to present a couple cases. You can see here in this video, we've got someone breathing, doesn't look like they're breathing very well, and we also see their chest x-ray. So let me give you a little bit of clinical background here. This particular patient is a 68-year-old female. She's got a history of coronary artery disease. She's got some heart failure, EF of about 20%. Coming in with shortness of breath, presented about 1 hour ago and got the following. They got a little bit of nitroglycerin sublingual, they got some Lasix, 40 milligrams, and now they are on high flow. Those are the settings. And you see the vital signs. They're tachycardic, they've got a blood pressure of 168/91, they're breathing 26, satting 93% on that high flow, and they are afebrile. So tube, not
No.
tube?
No.
No
I'm
tube.
gonna go with no.
No tube.
No tube.
Treat
But
them.
they're in respiratory distress.
The thing here that's key that you have to understand, you might end up tubing them, but probably won't, is they have dynamic physiology. And while that's not the treatment for it, if they give them real treatment that deals with the dynamic physiology they have, they will look much better in 15 minutes.
And Billy, when you say the real treatment, what do you mean by, did we give a fake treatment or just not enough?
No, they need more Lasix. Just kidding. Just kidding. Good thing we gave enough Lasix to pee. Lasix has nothing to do with this person right now. What they need is big time nitrates. They need someone to deal with the physiology. And then the next thing they need is someone to deal with some of the breathing with some, pulmonary support that will increase your oxygenation. And most of these people, yes, you might need to intubate them, but nowadays, well, I had a stroke, so I don't see anyone. But when I used to do this job, I had not intubated a patient like this in years.
Yeah.
Do we agree?
Totally. You have to do something more than having them lick the side of the bottle of nitroglycerin.
They
with
looked
the guy.
at it.
They just got a little.
Whiff of it, but no, that totally doesn't.
It's
count.
not cutting it.
Yeah.
They got a long way to go. And I think there are some really interesting, Swan-Ganz studies that show, giving Lasix really early on can actually increase some of your, afterload on the heart for a short period of time.
Makes them worse.
Yeah. And
Yeah,
so,
oh,
it's actually, we've done nothing helpful here. We actually probably hurt them a little bit. Yeah.
Absolutely. And how much nitrate we can have, you guys are ICU people, we can have a real discussion about that. But most ER docs are actually totally lightweights with this.
Yeah.
You can go up to, you can drop 400 on them if you want. But that you're talking massive doses.
Sarah, I'd love your opinion on that. And from a critical care perspective, I completely agree, we underdose nitro. We start like this tiny little drip of a touch of it. What would be your approach to this patient?
Well, so there's how much nitro I want to give them, and then how much nitro the nurse will actually give them.
Sure.
But this is the like Lasix Bumex thing. If I write for 80 of Lasix, everybody's hair is on fire. If I write for 2 of Bumex, people are like, oh sure, that's a normal dose. Same thing. If I write to give them 400 IV bolus times 3 of nitro, everybody's like,
Which
yeah.
I like. That's a good dose.
But it's a great dose. But if I'm like, give them 3 sublingual nitros immediately right after each other, everybody's like, sure, that's fine. Yeah. But it's kind of the same thing. So that's what I'll do. Because everybody loses their mind if I write for a bolus. So I just give it sublingual. Then I'll just start the drip at like 200. And I'm like, you can always turn it off. This is the beautiful thing about drips and nitro specifically. It's short acting. Just turn it off if they get hypotensive. And this patient, my bigger concern is that like they're just falling apart and their respiratory distress is a much bigger problem than blood pressure. And so I think the nitro, yes. The BiPAP, yes. Because part of my thing for this patient, we haven't maxed out their respiratory support. I would start them on some CPAP. That buys us time.
About this patient that tells me you're not going to need to intubate them is their blood pressure is pretty good. It's actually strong.
Got a lot of room.
I worry much more about heart failure when you make this person 90 on 60.
Yeah.
Now I don't have the room to work. It gets a little more dicey. But you show me those numbers,
Yeah.
Drop the hammer.
Yeah, we have some room. Although I have to take an issue with Lasix because I do enough CTICU. Okay, here's the thing about this patient. Is Lasix going to help them 5 minutes from now? Absolutely not. That's not going to help me 5 minutes from now. It's not going to help me not intubate this patient in the ED. But if I have a patient who's cardiorenal, I at some point have to get a bunch of fluid off them.
Oh yeah.
And if I wait too long, the problem with cardiorenal physiology, it's a vicious cycle. And if I let them go too far along into that vicious cycle, I'm going to end up dialyzing them. Then my charge nurse is going to be angry because now I have a CRT going on and it's no fun.
Have to put the line in.
Exactly.
Yep.
So that's why I start Lasix or Bumex or whatever early in these patients to get myself out of the vicious cycle. But that doesn't come into my intubation decision because it won't help me by the time I need to intubate them anyways. That's not going to get me out of it.
You asked for Bumex, at least when I was at Stony Brook and stuff. They look at you like there's something fucking wrong with you. Like, Bumex? Is that from like, what Eastern European country? It's like...
Yeah, I like that strategy. Order the unfamiliar med or confuse people with math. It's like, if you can move that decimal point,
No, they're too busy increasing the nitro by 5. That's because all the nursing protocols are like 5. They go up by 5, go up by 5. You're like, no.
Homeopathic
Up by
dose.
5 doesn't mean anything.
So it sounds like we're agreeing that this patient is under resuscitated. We want to give them a lot more nitro and hopefully
And
we
positive
would
pressure.
and
And
positive
positive
pressure,
pressure.
and we would hopefully avoid an intubation here. The rare case we may need to if they just continue to decompensate or their blood pressure is no longer tolerating this, but they're under resuscitated. We need to get positive pressure and nitro.
And when that fails and you have to do something like intubate them, that's the first reminder to you to broaden your differential and start thinking, what the hell's going on here? Is a valve gone? Is
Right.
because something else might be going on, and that would be one of my first hints was this doesn't work.
Right.
Yeah.
Because it always works.
All right.
It almost always does.
And the audience agrees with you guys. For the most part, we had 70% of the audience saying no, they would not intubate, and about 30% of the audience saying yes, they would. So sounds like we're mostly in agreement, but as Sarah Kreger says, it is complicated and not always a straightforward answer. All right, ready for your next case? All right, this patient, you see breathing, you see that they're in some respiratory distress, you see this not great looking chest x-ray. This is a 48-year-old with a history of obesity, type 2 diabetes, and is presenting with multifocal pneumonia. They came into the ER 3 hours ago, they got antibiotics, they got a liter of fluids, now they're on BiPAP with those settings. They're also tachycardic, they're tachypnic, they've got a decent blood pressure, 146/84. They are febrile, and with all of this, they're still only satting 91%. Tube, not tube.
I'm tubing this person.
Yes, me too.
I think
That's a tube.
the old adage is like, it's sometimes hard to know when it's too early to intubate, but you definitely know when it was too late to intubate. And I think that with this patient here, all the BiPAP is I guess the sort of start on BiPAP hopefully has a road to that, but it might have been a road to pushing it off to the next shift, like the underlying
also,
pneumonia.
The problem with the BiPAP, and I understand, you might try it. I would too. But we know that one of the hints for failure of BiPAP is an infiltrate.
Totally. Exactly.
And this person's got some failure on board and a bad infiltrate. I don't know which is which necessarily, but there's both. It's not going to go well. And the next thing that I always ask people when I'm talking about this with residents is, how much momentum does this disease have?
Yeah, exactly.
Are you caught up? What do you think? Is it all well, like the last one was? You can catch up and be well?
Yeah.
No, you will never catch up. This person might die despite your best efforts. So, yes, tube.
Yeah. I mean, what's my time course for recovery?
Exactly.
Like, there's a reason that COPDers and CHFers stick them on BiPAP, we turn them around in the ED, don't admit them to the ICU. When was the last time you did that with a pneumonia patient? Oh, wait, never. Because their time course isn't going to turn around that fast. And this guy, he's on maximal therapy. He looks awful. He's using accessory muscles. I think he's probably hypertensive because he's working so hard. The minute
He's the
you
kind
induce
of
him, he's
guy
going to
that
crump.
when you intubate and respirator
Exactly.
falls.
He's going to fall apart. Totally. And I want to do that sooner rather than later. And it's just a matter of like starting some pressors and resuscitating him because you know he's going to crump. Don't wait for that to happen. Just start him on a little norepi and ready to do this. And then you're intubating him anyways and see what happens. But no, definitely a yes.
All right, so we're tubing, and in summary, it sounds like, the first person we had, there's some reversible things there. This is a sick patient who's going to be sick for a while despite all of our best efforts with all the positive pressure that we could possibly give. So, intubate. All right, and our audience.
Just one other thing.
Oh, yep.
The BiPAP. So they give us the numbers they chose, just for yucks. So there's a whole conversation to have about the BiPAP numbers they chose. I'm all right with pushing my BiPAP numbers way beyond where most people are, but again, not on a guy with an infiltrate. Anyway, putting someone with an infiltrate on BiPAP 22 and 14 is let me drive the infiltrate into the deep posterior recesses of his
Really
pneumonia,
shove it in there.
where it will eventually become an empyema if he lives.
Well, it looks like the audience also agreed with our team of experts. Let me see those numbers again. 13% said no, they would not intubate, and 87% said yes, they would tube this person. But tricky, right? These cases, the clinical scenario matters because both of these looked like they were breathing pretty terribly, but one we would tube,
And some
one
of
we
the
wouldn't.
people who said no might have said a little bit of resus first. I'm okay with that if we have that discussion. If I'm moving directly towards it, but I want to do a few things first, I'm okay with that.
This is going to be a tough intubation, whichever way you slice it. Like there's no positive thing going here in terms of the actual technical intubation and how hard it's going to be. So I can see that.
All right, I got one last case for you guys. Again, another video of someone breathing not great, a chest x-ray, which doesn't look that impressive. This clinical scenario, we've got a 77-year-old male. He's got a history of dementia, hypertension, hyperlipidemia. He comes in from EMS as a code stroke. Apparently, he tripped and fell in the shower and is now altered. He is not withdrawing from pain, but he's not doing that in bilateral upper and bilateral lower extremities. Code stroke? I don't know. He is on 6 liters of nasal cannula. His heart rate is 108. His blood pressure is 132/86. He's a little tachypnic. He's satting 95% and is afebrile. What do we think about this case? Tube or no tube?
I don't think this guy has a stroke. This guy doesn't have a stroke. They always come in as a code stroke. And the neurologists are like, what do you see on this picture? And you're like, but look at his abdominal breathing.
Right. This is a tube.
Yeah.
This is probably a C-spine injury of some kind, and he's doing that sort of paradoxical breathing. And this is another thing that I can't fix, in any short period of time. And with those kind of comorbidities and that age, this isn't going to last for too long. Although this is not going to be an easy intubation. This is a very high risk intubation. So it's got to be well planned out and thought about, because this is somebody who you really can't move.
Right.
So, but this is somebody who's going to need the respiratory support.
I just have to say, because I know I'm the only person here who's done it, I called, Stony Brook has the CT scans in the ambulance.
Yeah.
We have two
Yeah,
of them, the whole deal. So when I had my stroke and I was on the floor in my living room, kind of in disbelief that I couldn't get up, I called Code Stroke on myself. So I called, they picked the phone and said, "Hi, Dr. Mallon." They said, "Oh, hi, doctor, what can we do for you? Come to my house." They were very confused. And I finally got them to realize, "No, you need to come to my house. I'm having a stroke." And they were all excited when they got there. This is all about the search for the ischemic strokes, or the CPA. And as soon as they got me out to the rig and they did my scan and all this shit. And then they were just bummed. And I unfortunately knew what that meant, which is that it's a bleed. Because, all right, just take them to the hospital.
They really wanted to reverse something for you.
They wanted to do it, but they couldn't. It was so funny. I came in, I'm on the phone, on the floor of the living room. "Hey, guys." And I told them, I'm not going to be able to talk soon. But, and I couldn't. By the time I got to the hospital, I couldn't talk.
Only Billy Mallon could call a code stroke on himself and be completely accurate and correct in his own diagnosis while on the floor. All right, so we all agree that we're tubing this person, right? This is not a stroke patient. This person is having some difficulty breathing, not from a stroke, but probably from that C-spine injury. I'm assuming they have.
That's a good example, a really nice example of belly breathing. And that belly breathing is a little bit subtle sometimes.
Yeah.
You have to look at that for a second. Right. You got to focus. I always used to, it's a long conversation. I'd love to have it sometime. But I used to tell residents that they didn't know how to see. And they look at me like, "What's wrong with him? Can I have a real attending that won't say stupid shit like I can't see?" And I used to tell them that they can't see what's right in front of them because they haven't learned how to see. And it takes some time before you learn to focus in on certain things. And respiratory is an area where to look at their mechanics, interpret how they're breathing. Obviously, people in the ICU do it more than we do it. But ER docs should be really good at it. And that breathing is a problem.
And I think the other thing, maybe not exactly for this case, but it might be important to highlight, obviously this segment we're doing is about tube or not, but in people that might, a really elderly person, that there might be a little bit of time to make this decision, kind of once we go down that pathway, we're committing that person to probably a trach, peg, the whole thing, when there might actually be family on the way, there might be other directive or stuff that we could find out. We're freaking out about this breathing, but actually they've been holding their own for 15. We have a little bit of time to help make a decision that's more patient-oriented potentially, rather than pull the trigger right away.
Unlikely.
Unlikely.
But it can happen.
Yeah.
And in general, I think we have more time than we think we do. Yes. There's very few situations when I'm like, we must intubate them right this second.
That's right.
Massive vomiting of blood, 100% intubate them right now. But most of the time, even when they look bad and their sats are bad, you have a minute to just don't do something yet. Just stand there and think about it. And you almost always have time to do that. You just need to give yourself permission to actually do it.
Yeah, I agree with that.
All right. Well, the audience also agrees with the experts. About 77% of audience members, are agreeing that they would intubate this person. So everyone agrees this patient gets tubed.
And most of the audience would intubate me, just to shut them up.
Can we take a poll?
That will not be a poll question.
They'd be worried about the post-intubation critique, though. They'd be they'd get the notes afterwards. That's right.
All right. Thank you guys for playing along in this tube or not to tube segment. We're going to move on to What Now with Sarah Kreger. Okay, so we call this segment What Now? But this is really just like kind of my real life with Sarah, to be honest.
The 2 a.m. phone call.
The 2 a.m. phone call. I am lucky enough to have her on speed dial, thank God. Because I sometimes reach these situations where I've done all the things and gone to every end of my knowledge and something's just not working. The monitor is beeping, the patient is crashing, and this is when Sarah gets a 2 a.m. phone call.
It's the like where the sidewalk ends moment when you're like, I've done all the things, but oh, I'm done all the things. What now?
And now I need my ICU friend. So, Sarah, this case I had not too long ago. This was a 90-year-old guy. He comes in altered. He had been found down. We were thinking he's probably septic. This guy is definitely not protecting his airway. He's probably aspirated. He's not breathing well. He's in distress. This person did need to get intubated. So we intubate this patient. Super smooth intubation, everything's great, vital signs are okay, he's satting 100% post-intubation. We get a chest x-ray, tubes in the right spot. Lungs don't look great, but again, we think he aspirated, probably has some ARDS and pneumonia, and just not looking great. So I leave, and then about 15 minutes later, the resident is like, Dr. Guest, I need you to come back in. And I'm like, what, the patient's tubed, he's going to the ICU, high five, we're done. And they're like, except he's getting more and more hypoxic. And I'm like, but we intubated him. We did the thing. So he's now satting, he goes 80s, 75, going in the 70s. So I start my kind of algorithm that I have in my head, right? All right, listen to breath sounds. Are they bilateral? Do we have a pneumothorax? Bilateral breath sounds were present, so no pneumothorax. Okay, so I can rule that out. Reshoot an x-ray just to make sure the tube didn't get dislodged or displaced or something weird. Tube's in the same spot. I get RT to suction him, thinking maybe there's some mucus plug, and maybe that's our issue. We suction, but there's nothing.
Still satting 75.
And he's still satting 75%. Okay. So I'm like, okay,
what
so
now?
no pneumo, tube's in the right spot, the x-ray looks the same, more or less, nothing's getting terribly worse, and there's no mucus plug.
Okay. What kind of PEEP was he on? Well, who put him on the vent settings? Did you put him on the vent settings? Did the RT put him on the default vent settings, which kill me, the default vent settings?
I am going to be honest that the RT probably just put him on the default settings.
Happens every time.
So that, I hadn't, the monitor wasn't beeping at me yet. The vent wasn't beeping.
Okay.
The patient was just giving me the beep of I'm still persistently hypoxic, despite all of my going through my algorithm, and then the sidewalk ends.
Yes.
And he's still satting 75%.
And so your default PEEP is almost always 5. What is magic about a PEEP of 5, an FiO2 of 100, a tidal volume of 500, and a rate of like 16? I don't know, but every patient gets those settings. They're not the right settings for almost anybody, so I don't know why they all get them. But this is a very common problem. You're all excited, you get them intubated, and you think you did great because you're bagging them, and they're perfect, they're fine, they're satting 100. Mm-hmm. This situation happens all the time, where you connect them to the vent, walk off, you move on with your life, and then you get called back, and now they're desatting.
That was the problem.
And there's the obvious things, and you did all of the usual obvious things.
Well, and then, so I did go to the vent, and I said, okay, the PEEP is 5. The PEEP is pretty low, so let's increase that to 15, which I did.
Okay. And?
Still 75%.
Okay.
Now the sidewalk has really ended.
What do we do? Because I think most people know, like, let's go up on the PEEP some. And
Yes.
I'm like, it makes me so happy that you went all the way to 15, because some people are like 8, maybe 10, and they're afraid of PEEP, like the patient's going to explode. I don't know.
I think their alveoli are happy, though.
Well,
Popping them
they
open.
can be. That's the idea, right? But what happens if this doesn't work? So if this doesn't work, there's a couple of big things that you should try and think about. The first one is really, really simple. Sit the patient up especially if they're obese. We do this crazy thing that we lay people flat to intubate, which I don't think we should do in the first place, but that's another conversation. Then we just leave them laying flat. And if they're morbidly obese, you now have this abdomen and this chest mashing on the lungs. It's not helping you at all.
It's like the
Sit them
cement
up.
bag that's
Exactly.
just sitting
It's
on their
blah.
lungs.
Right, sitting on their lungs, not helping. Sit them up, step 1. 2, sometimes if you come back, especially after coincidentally an hour if you intubated with rock, they're suddenly mysteriously desatting. Why? Dysynchrony. I've been super impressed in a bad way by the degree to which vent-patient dysynchrony can cause desats. Because if the vent's trying to breathe one way, the patient's just fighting and trying to breathe another way, is not going to go well. So sometimes, if I really don't know what's happening, the patient is just like really fighting the vent. I've given them a bunch of sedation and it's just not working. I'll just give them another dose of rock and reparalyze them to sort it out. Because trying to figure out a vent and a desatting patient while they're like and overbreathing the vent, it's like trying to read an EKG in a patient where they're flailing everywhere and the baseline's doing this. You can't figure out what's happening. So either
That's a good
first,
point. That's a good
sedate
point.
them deeply, because you cannot paralyze somebody without sedating. Deeply sedate them, give whatever you need to do, and don't be limited by their blood pressure. That's what Norepi's for, right? Don't be like, well, I can't sedate and paralyze them because their blood pressure sucks. Start some
And they're
Norepi.
already intubated,
That's the thing.
so-
problem solved.
Yeah.
So that is thing number 2.
Okay.
Are they synchronous? Do they need deep sedation? Paralysis? Sometimes that'll help you.
Got it.
If that doesn't work, now we need to take a closer look at the vent. And the first question you ask yourself is simply, are they breath stacking? You look at your waveform, because often they are. And if that's your problem, then your solution is easy. Disconnect them from the vent
And hug them?
and hug them, or sit on their chest, or I prefer
Squeeze.
to push on their chest, and I like to get up close with my patients, but hugging, when they're
Hugging would
vented,
work.
You can hug them if you want. Point being, disconnect the vent, push on their chest, push the air out, and see if that works. Because if that's your problem, nothing else will work. And if that's your problem, then don't just restart them on the same vent settings that didn't work the first time. Slow down the rate, lengthen the I to E, try again. Now, if they're not breath stacking on the vent, that's when it gets a little bit more complicated. Because if they're not breath stacking, you might be able to solve their problem with PEEP. But often what happens is this. You go up on the PEEP, especially if you're being
that.
appropriately aggressive.
Right.
And often the rate limiting step, now your high pressure alarm starts to go off. Now, if that happens, you can still keep going up on the PEEP if you need to, but here's what you need to do. If you're on volume control, which almost everybody is, which is set the tidal volume that they get, that's what we almost always do. What you need to do is go up on your respiratory rate and down on your tidal volume. Because often we'll start people on like 18, which doesn't make a lot of sense. You know, high tidal volumes can hurt the lungs, high respiratory rates, not so much. So you're gonna come down on your tidal volume, go up on your respiratory rate, then that often gives you the pressure room that you need to go up further on your PEEP. If that still doesn't work, you can do what I call the recruitment maneuver for dummies, or the recruitment maneuver if you've only read
For
about them or
dummies
heard about
is
them,
for
or
grit.
or for anybody, because you know the thing about recruitment maneuvers, they can be dangerous. Like on a vent, if you don't know what
Right.
you're doing, you've never done one. So here's recruitment for dummies, or for like you're like the vent. The button, is there a button that says recruitment maneuver? There's not. So this is how you do it. Okay.
We have an
the
intubated
ETU.
patient.
Ta-da, we have an intubated patient. Okay.
Ta-da.
So all you do is you're going to disconnect them from the vent. You are then going to simply bag them, but you're going to bag them with a lovely, lovely PEEP valve. Ta-da! This is a PEEP valve. Wonderful, wonderful device. So you bag, and often you'll find as you're bagging, their SATs will get better, but you have a tactile stimulus. This noise is delightful. And then you all laugh about the noise. Anyways, so you're bagging, you have tactile stimuli to sort of, are they really hard to bag? That gives you information. You're not going to blow up their lungs. You're bagging them with a PEEP valve. They often get better. Their SATs come up. You've just recruited them in a safe way. But then you do this thing where you then disconnect them, you reconnect them to the vent, and you do this experiment all over again 10 minutes later, because you know what happens to all that lovely recruitment that you just got? All literally out the tube, right? Because the minute you disconnect this and you break the circuit, we've all lost that lovely recruitment. You know what you do instead? As follows. Okay, let's say we're gonna recruit our patient. So, we have our PEEP valve, bagging. Okay, SAT's 100, I now want to put them back on the vent. You're gonna find a buddy, you're gonna find a Kelly clamp and some tape. You're gonna take the tape, wrap it around the teeth of the Kelly so you don't damage the tube. Then we're gonna do a clamp switch. Requires 2 people. You're basically gonna say, okay, I have my vent ready, we're gonna put the patient back on the vent. I'm gonna bag one last time, then, it's gonna make that noise, and then I'm gonna clamp, then my buddy is going to remove the ambu bag, connect the patient to the pretend ventilator, unclamp, voila, we have now switched the patient over without losing all that recruitment. And this is a technique, it often works. And the nice thing is you don't have to understand anything about vent waveforms. You don't have to be comfortable with PEEP or recruitment maneuvers on the vent for this to work. You just have to remember to clamp switch them back on the vent once you're done. So that's what
Next time I will do that. But I hope this was helpful because I think the sidewalk ends for many of us in that position where, you know, you've ruled out the pneumothorax, you've ruled out the mucus plug, you've made sure your tube's in the right position, you've increased the PEEP, you're not breath stacking, but what now? And that's an easy way safely to recruit, doesn't require much equipment, all we need is a Kelly clamp and a BVM, and the patient's back at 100%, hopefully.
Hopefully they say that way.
All right.
And then call the ICU.
And then call Sarah. All right, so...
The ICU, not me personally, necessarily, just to be clear.
You don't want us to give your phone number out to everyone?
Not to everyone.
All right, so now we're going to end with our board certified case. So we'll transition back, join with all the faculty to run through a complicated case, I am sure.
Too oaky. Awful.
Lame.
What are you looking at? Too piney. Don't like it.
Boring.
I can't see. Too woody. Bollocks.
Boring.
I said I can't see. Not woody enough. Absolutely awful. Ow.
All right, so this was an actual case I had where I was down in the ED and there was this patient who'd been admitted and was boarding. And I'm sure all of you are very familiar with the lovely boarding situation everywhere right now. So this lady was boarding for like 13 hours. I hadn't seen her primarily, you know, the people in the ED, they hadn't seen her primarily. We just got called to the bedside for unstable AFib. So here's the situation. She was 78. History of diabetes, arthritis, history of AFib, embolic CVA, and since then had been kind of bedbound and had developed this sacral decube. EMS brought her in because the family was like, she's altered. The patient, all she cared about was her knee pain. And I go in and I examine her, and she's pretty altered at this point. You know, she's like ANO times like maybe 1 to 2, and she just kept being like, my knee really hurts. Okay, well that was her chief complaint, in fact, when she presented. But, you know, she had a UA that was grossly positive and she was altered. So she got admitted for urosepsis. And it was reasonable to admit to medicine at the time. Her vitals were kind of okay on admission. I mean, like, plus minus, a little bit tacky, but not terrible. And her labs were not awful, right? Her lactate's a little high. Her creatinine, her baseline was like 1, so it's a little higher than her baseline. White count's a little high, but she's uroseptic, you know? Like, we're not that excited about this. So at the time, they were like, let's admit to medicine. That was in the morning. Then let's go to what happened next, because at some point somebody was like, okay, your chief complaint's knee pain, let's just do a knee x-ray, and it was also fine. Very unexciting. Things didn't get exciting until later. Things got exciting when I get called on her, and now her AFib is like 135 to 140. Now she's hypotensive, and she's really quite profoundly hypotensive. People have been fluid bolusing her, and she's just not responding to fluid boluses. She's getting tachypnic. Her sats are hanging in, she's febrile. So I was like, maybe we just overdid it with the fluid boluses, you know, like maybe we put her into cardiogenic shock, let's take a look. So, stick an ultrasound on her, probably not. Her LV was hyperdynamic, her RV was fine, her IVC was collapsible, she had no B lines, and then I was like, well, maybe she has an infected stone, and I have that, nope, she didn't. No hydronephrosis, that did not seem to be the issue, can't fully rule it out, but meh. And then I'm like, okay, let's send some labs and figure out what's going on. And we send these labs. And they're starting to look really quite concerning now. And I have a nurse standing next to me being like, the medicine team ordered some beta blocker because unstable AFib. And I'm like, whoa, 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 let's take a minute and try and rethink this because I don't know what's going on. But I don't think that the AFib is the culprit here necessarily. But I'm really beginning to think that the urosepsis may not be either. What do we do now? What are your thoughts?
I think it's generally a bad sign when the respiratory rate is bordering your diastolic blood pressure. That's got to be something.
Two numbers
some
are supposed to be
predictive
different from each other.
there, you know?
Let's call it this Kobner sign.
Yeah. And although this is, you know, she does have AFib and she is hypotensive, I'm not sure I'm going to be reaching for a beta blocker at this moment. Well, one, I don't think that the beta blocker would be the best way to treat unstable AFib, because if I thought it was just primary unstable AFib, she needs to be shocked. but I don't think this is just, I think there's probably something else going on, and I'm not totally convinced that it's just urosepsis at this moment, but something else is going on that we need to address that will start to fix the AFib.
Totally.
I know how this goes at Stony Brook. Me, as the attending, walking around, pissing the residents off when I say, what's under the fucking diaper?
And well, I do have a question about this particular
It's a hint,
patient.
it's not beta blockers. That's not what we're going to find out.
Because I totally agree. I wonder, and this is no judgment, but I wonder, especially being in a place where there has been so much boarding, is this patient in a room? Is this patient in a hallway? Has someone is this patient in a gown? Because that can even be difficult when we have such a big issue with boarding and not having enough staff.
There's all kinds of excuses, but I'm betting they're in a diaper. The story you gave is, someone be like that. She's got this the cube, which could be more infected. I didn't hear anything about that. But I'm feeling that no bueno. I don't know what it is. I'm just going like this. that there's shit down there that's not good.
So can we get an exam?
Yeah, I think, we're in this board certified section, and when you're taking the boards, one of the things when you get information that things are going the wrong direction, go back and start over, right? Go back to your primary survey, go back to square one and start over. What am I missing here? Because we're missing something here. So we don't know what it is. I agree with you. The AFib that's a red herring. These labs are these are bonkers. Go back, start over, square one. Let's pretend like I'm starting from scratch, and that includes a good exam, and that includes just rethinking the whole thing, and not anchoring the anchor bias on the urosepsis.
Totally, because that's the thing. And I think in a board situation, or in this situation, it's really easy to do that, But I think we all need to have this mechanism, I just call it a reset moment, because if you get the call and you're in the middle of a shift and they're like, this lady got admitted for urosepsis and she's in rapid AFib and I think she's unstable AFib, you go to the bedside and that's what you start doing, And so I think it's easy to do it right now, but we all need to very consciously be okay, sometimes it really is just as simple as it is, and sometimes it's not, and I'm just going to mentally reset and forget everything anybody told me, go all the way back to the beginning, and start over again. And I've messed that up enough times that I call it something specific. And so I actually went back to her knee pain, because I was the only thing this woman's ever actually complained of was her knee pain. She wasn't complaining of dysuria, she wasn't complaining that she was altered. All she keeps saying is my knee hurts, my knee hurts. So I went back to her knee pain, and not terribly surprisingly, ultimately it actually wasn't her knee. I was do you have a septic joint? What's happening? But
I've seen it be that.
Because it could have been, she's having knee pain, the x-ray doesn't show anything, but of course it doesn't. But it led me to continue examining her, which ended up really being where the money was. Because, as you had expected, nobody looked at anything. We are boarding like crazy, everybody's in the hallway. Now, she was in a room now, but it's a little harder for me to fault the person who did this in the first place because she wasn't when she got here,
Yeah.
And so eventually, I ultimately examined her knee and was that's fine. Your knee's fine. Maybe you have arthritis, but there's nothing wrong. But she was really tender in her thigh. And I would have liked to think that I would have just automatically examined everything if that hadn't been the case. I didn't have to find out because she was tender. And I kept going up and I was you're really tender and really tender. And finally I just took everything off, and then I was oh, that's not good.
What was it?
Well, Rice Krispie treat style crepitus,
okay,
everywhere.
But it could be anything.
But this is the thing, you just don't know.
It could have been. I've taken the diaper off in these situations, much to the residents' horror, and there was stool draining out of the skin.
Yeah.
I was dude. One time I had a resident come to me and I was same kind of thing. We took this off. Person had big, bruised groin. They'd had a procedure done. And I looked at her and I said, did you listen to that? And he goes, just looked at me like I was from another planet. That old man, Dr. Mallon, asked me if I listened to his thigh. Well, he had a huge bruit and an obvious AVM that you didn't really need angio suite to diagnose it, your ears would be just fine. But we had to call them to do something about it. Anyway, it's, what's under the diaper? What's under the diaper is important in peds. Usually it's nothing, but that's peds. What's under the diaper in the oldsters is always bad. It's bad.
And
It's
also
bad.
one of those times where like the the UA is falsely reassuring and it angers people. Like
Totally.
it's grossly positive. It might have been gross, but not necessarily positive. You know, like we got a urine sample that was scraped off of the innards of someone's thigh, and there's a million squames and everything else in there. And really, the leukocytes that we got were actually from like the Fourniers, you know, like or whatever else is happening. And we just stopped because it like, oh, there's a little bit of a leukocytosis. This is probably urosepsis, and then they don't go back and take down the diaper or do that because we've reached that closure. With
Altered little old
Yeah.
lady with a UTI on UA, like you're done, right?
Yeah.
And
But I
we
think
see urosepsis
Well,
all
exactly.
the
Yeah.
time.
And
Sometimes
some
it's just
people would say,
urosepsis.
and this might be too crass. I probably shouldn't
Even for
say it.
Billy. I'm scared.
I mean, she's going to die. So maybe it does make a difference to look under the diaper. She's going to die.
Well, and
in theory on the case.
And like we see urosepsis very frequently, and sometimes we do see those patients where you give all the appropriate antibiotics and they get worse, and so that could be going on. But also, I mean, her lactate is crazy now. I mean,
Something's wrong.
her creatinine's going up. All of these labs are going drastically in the wrong direction, and I think, like Jan said, it's
I was
so
interested that her
important.
sodium didn't drop
Yeah.
Now,
more.
although that's interesting because I was going back over this case to sort of be like, could I? And I think that she was also probably profoundly volume down when she came in. And any kind of sodium, whether it's hypo or hyper,
Yep.
is impossible to interpret if they're not euvolemic. And so I think that, I don't know. We did, however, at some point check a CRP, and it was 238. So,
But Sarah, when you said that you did this exam and you're looking at the knee and then you're going up and you're getting a lot of
Yeah.
crepitus and there's a
Yeah.
skin exam that's probably not so great.
No.
Did we get any further
We
imaging on
did.
this patient?
We did, and it was very impressive. So we got a
Okay.
CT abdomen pelvis, and the first thing that was impressive is that we can now see why
Oh,
she had a
she's
positive
constipated.
and her bladder's massive and whatever. But that's where it gets really impressive right there with all that air. And in fact, she had Fourniers.
How did she even give a urine sample? That bladder
That
is so
such a good question.
distended.
I
Is
know.
she
That's
peeing?
such a good question. I don't know, but it probably was infected. But again, it's a true unrelated thing, right? And I think one of those things, like in little old ladies who are altered, some of them are going to have UTIs, but it may be true unrelated because UTIs are common enough that may have nothing to do with anything at all. And so I think in her, and as you said, like in this particular case, Fourniers to that extent in a woman this age, like she wasn't going to. But we could have found something, like let's say we didn't see all that air,
Yep.
and it was just she had a bladder obstruction, and all we needed to do was put enough Foley and decompress it and get all that
Yep.
infection out. Well, voila, there we go. And so I think in the light of day, this case is, I mean, it's not straightforward, but it's also like, it's like one of those classic boards
Oh, this
cases.
is the kind of case
But
that creams you when your department's reviewing it. I mean, whoever was responsible for the first go around, and God knows I probably have been, you're gonna eat that one. All you can do is just kind of quietly slink out of the room.
And I mean, I absolutely 100% agree. Everybody needs to get a full exam. Everyone needs to be in a room and have a gown.
Yep.
It's been tough recently. So, if you have someone that's a little altered and good vital signs and a positive urine, I totally see where this person went with, okay, we'll admit for antibiotics and it's just the urine. And they would probably be right 99% of the time. But I mean, like Jan said, going back and starting over from the beginning when the person got the right treatment, but for the wrong thing and isn't going in the right direction.
And I think that's such a key point, and especially, AFib with RVR, and unless it's like somebody who's just like, I just started feeling palpitations 10 minutes ago after whatever, it's like, for me, it's always, that's the diagnosis of exclusion. There's always something else that's driving it, and especially in someone that you got a sign out on, it's unclear what's happening, like, that's a head-to-toe reset for me because I need to figure out what's actually driving that. And it's going to be like you're saying, the reason you're drawn to the bedside.
So mad that they hadn't gone upstairs. Because as soon as I even start thinking about this, I'm like, Christ, I gotta. Now I'm lucky in that usually with residents I can make them look under the diaper. But that's such a horrible situation. And you're now 12 hours behind the 8 ball. It's a mess. Somebody's missed the correct diagnosis. You don't know what the correct diagnosis is, but you know they don't got it.
Something was clearly missed. And I think the hard thing for me is, in these nights, because this was on a night shift and there's a bazillion patients and I cannot devote that much time to everyone. And I think that the sort of clinical gestalt judgment and how do you develop my time's a zero-sum game. If I spend a ton of time and do every little thing with every single person, I'll miss the big things in the patients who are sick. But if I completely fail to do that, I'll miss this. And so how do you sort of apportion your zero-sum game to be like, this patient needs my time. This patient, maybe they simply just do have a UTI. And so, you guys have been doing this a lot longer than I have. Other than this sort of reset moment when something doesn't fit, do you have any words of wisdom on that game of like zero-sum time game?
Start over.
Start over, yeah. I mean, just, trust but verify. Recognize that people make mistakes. Just reset. In UAs, UAs can just take you in so many wrong directions, and that's one problem.
Pylo that isn't.
The pylo that isn't. We have a whole lecture on that. That's true. So I don't blame the person who. I agree. I think all the points that were made. I don't blame anybody
It could happen
for
to anyone.
Totally.
I just think these are the times we live in, and it's a risky business that we do. And so when you're handed that kind of labs that have just gone this direction, you just have to start over. And as much as like you go. Like you said, I'm being pulled in a million different directions, and now I have to go take care of this boarding person that isn't even on my list, But now I have to have an end of life conversation because honestly, the ending of this story is not good. So and now how much time is that going to take? So
it's like you're reading my mind,
right?
In fact,
and I also think it's also a good learning opportunity for the whole team to work together, like with nursing. So if somebody changed a diaper on this patient, or maybe did an in and out cath to get the urine, and they're like, I thought it was weird when their leg felt like Rice Krispies, but
no, they thought it was weird when they almost vomited from the stench.
Yeah, exactly. But hey, maybe next time let somebody know about that. And if they're the one who's notices it first, maybe at that change of shift, and they did the exam, it could be a helpful way to close the loop on some of these patients that when they're boarding, you're kind of collectively taking care of,
Yeah.
There's time efficiency there too. If they're going to go in with the rectal temp or do a Foley, just call me when you're going to do it and let me pop in there with you. Let's just do it together, right? The more that you can duplicate your time and spend that extra time with the nurse, you're both doing the same thing at the same time, you're just saving time overall.
Speed is the enemy of thorough.
Yeah.
And sometimes the people who are really thorough and slow, you think, boy, they're really good. And their patients, both of them, think it's true. But they're killing the guy who's working with them, trying to see everyone else.
Yeah. Totally.
At little company, the doctor will remain nameless, but my line for him always was, he takes really good care of both patients he sees. Both patients he sees are super thoroughly done, and he documents everything.
He knows the name of their kids, their pets, what child goes to which school.
I don't know how he finds the time with both of those patients to chart all that. Meanwhile, the board has 2 names for him, the 2 he's seeing, and 30 of my name, or whoever he's working with.
And I think, and I 100% agree with Jan, one of the ways to combat the I don't want to move too fast and miss things, but I don't want to move too slow and make the rest of the team unhappy, and exactly what Jan is saying. When I go in with a resident, I even go in with them, and it's like, okay, we've got the nurses, they're putting them on the monitor, we're going to get a rectal temp, we're going to take down the diaper, we're going to roll this patient. Don't leave a room with an exam undone. If they're in the room, you're all there, do the pelvic, do the rectal, do the, maybe, you can't avoid these exams, and if you do, you're going to miss something. So get it all done in one spot, because I think what takes longer is going back and forth forth in and out of the room. And if you have to gown and this person's really sick, get in there, do it once, and do it well.
We do it in trauma pretty well, and you just need to treat a sick medical person like you do a trauma. You know, just like be thorough, top to bottom, do the roll, take a look at the back. Like let's just rule all look at all the stuff for your altered mental status. Do it that way. Just get it done. And think of it that way, and it actually in the end saves you time.
Yeah. And I think your septic patient, you need to think about that way.
It's
like it's all about finding your source, because often it's one. In this case, right? Like her bladder's massive. I'm sure she does have a UTI, but probably because things are obstructed because she has Fournier's. Yeah. And so I think I like that idea of like I'm going to think about my septic patient like my trauma patient. Yeah. I'm going to go head to toe, do the whole thing routinely and systematically to find my source, basically.
Nooks and crannies.
Yeah.
You got to look in the nooks and crannies,
especially the nooks and crannies. Awesome.
All right.
Well, that is that case. Thanks, guys. And
That's a
then-
tricky one.
Britt,
And even on the, in board land, when you actually are doing oral boards, because I did them not too long ago, you draw your little stick figure. I'd always have to make an image to ask about the skin. Mm-hmm. It's so easy to forget to ask about the skin. And that was definitely something that was missed in this patient, which is also very easy to miss on the real boards. So ask about the skin.
And what temperature is it?
Yes, and temp. Okay, so we've got a few questions from the audience. One, actually, Billy, I wanted to direct to you. You had mentioned with that ferning picture and the lightning that there was no pupillary reaction, and people were asking about that. What's the mechanism there?
So with a lightning strike, oftentimes, it's not everyone, because there's a whole variety, but for more severe lightning strikes, the person is down. And in that kind of patient, you go to them and you are facing a situation where they have their light, they don't respond. It's part of the paralysis of their ocular muscles, not just the iris, but all of them. It'll go away in about 15, maybe 20. But you look at them originally and you think, oh, I don't know what happened. They're totally not reactive. That's one of the things to know about lightning strikes.
Okay, so it's part of that transient paralysis.
Yep. And they can't breathe either.
Yeah.
A lot of times they aren't breathing, so you have to breathe for them, but they have a good pulse. When you first see one, you can be really kind of confused. That's lightning. It's confusing.
You can get those paradoxical arrests where they're in asystole, but they come out of asystole, but then go back and degrade because they're hypoxic because they're not breathing for them again.
So let me digress for 1 minute. I was teaching ACLS, and I tell this story where there were 10 people in the weather shack on Mount Whitney, and the thing got hit by lightning, and 3 people went down. All of them down, out, no pupils. And this medical student didn't know much, but he said, look, they don't need CPR, but we got to breathe for these people. So he set up a chain of respiration for them.
Wow.
And they actually walked out with them. And eventually their pupils recovered and everything. So he's in my ACLS class.
Really?
And I tell the story, and he goes, that was me. I go,
no way.
No way. So I just gave him his card then. I said,
you can go.
You are excused. 3 people.
Wow.
On Mount Whitney.
That's an amazing story.
No pupils, good pulses, no ventilation.
Bag them through it.
No bag.
Oh,
just breathe.
Mouth to mouth.
Mouth to mouth.
We're on Mount Whitney. We're getting personal. All right, Sarah, the next question I'm going to address to you. When we were talking about treating this person with nitro, the one that we were talking about, intubate or not to intubate, and that we needed to aggressively treat them with nitro, can you walk through what a typical bolus and drip would look for you?
Yeah. So I, again, will often start with the sublingual. Partially that's because I can give higher doses, partially because it's right there in the Pyxis. I don't need to get the drip set up, I don't need special tubing, so I actually just usually use the sublingual as my bolus functionally, and then I see how much the pressure comes down. And then it depends, because if I've given them 3 sublingual sort of nitro, and their pressure is still 180 over something, then I'll start bolusing them. And I'm not like leaving the bedside and writing orders to do this. I'm just like going to stand there. And so then I'll bolus like 100 at a time, maybe 200, and then I'll just kind of stand there and see. But I'm also simultaneously going up on the drip because it's so short acting that it's not like you're going to bolus them and fix the problem. To me, it's more, let's get you loaded, let's get you started, and then let me get a sense of how much you're going to need. And then every time I bolus, I see how they respond, then I go up on my drip. And so I'm starting my drip at, like maybe 100. And if they're really coming down with their pressure, then I'm backing off. But again, nitro is very beautifully short acting. It's not going to last all that long. So it kind of depends, but again, really, once you get them on a good high drip rate, it's just that the big mistake we make with nitro is we start at 5.
Right.
And then we're like, oh, it's not working, because by the time we get to a usable dose of like 200, it's 5 hours later and the patient's now intubated. So again, the bolusing is just as much to sort of get yourself to a high dose on the drip that's going to do something rapidly, because if you leave it to the titration protocol, you're going to get there 3 weeks from Tuesday.
Yeah, which is really interesting because I think like when you actually go in like Epic at least, when you go in and order a nitro drip, it does start at like 5 or 10, and like Jan said, they titrate by
Standard is
5.
5-10.
Yeah, it's just a sprinkle of nitro, which is not what this patient needs. They need a strong, solid bolus.
Yeah, but you got to be in there.
Homeopathy.
Yeah, it's and homeopathic. It's like propofol. The propofol protocols start at 5, and I'm like, no, they're still paralyzed with rock. That's homeopathic. But again, I think this is not a time that you're over there. Like you're in there, you're doing this yourself. You're with the nurse, because that's also what they're going to need. Because you can't just be like, just go off protocol. Because I said though, you need to be in the room doing it yourself.
This is particularly true right now. We have so many new nurses joining our teams and travelers and things.
It's hard for them.
And they're trying to follow. They either don't know the rules or they're trying to follow the rules because you know. So when you're really asking people to do things off protocol, especially right now with a team that you don't know, you really have to be there and do it.
You got to be there yourself.
All right, and then Scott.
Yes.
That mystery image, which I swear is just someone that's tipped upside down. Can we talk about that? Because somebody did get it. We do have a winner.
I think we do, from the Lucky Pocket.
What is it?
Their name. Do you want to advance the slide? Yeah, we got the picture here, right? So this is a patient that previously had a retinal detachment, and so they had a silicon oil infused into their eye, which is a lower density than the vitreous humor.
So it goes to the top.
Exactly. So like they have the patient, lie on their stomach. The oil pushes the retina back to the posterior part of the eye, lets it set in place. And sometimes they can't get it all out, or they don't get to, or something happens, and it sneaks in through the anterior chamber and rises to the top. And it looks just like a hypopneon. And if you look really closely at the image, you can see the little bubbles in there. So it is actually just some of that silicon emulsion.
Cool.
Which is pretty fun if you ever see one in real life. I've seen a few of these at County, actually. It confused me the first time. I was like, what is going on?
A few of that?
Yeah, we had a few. It was pretty wild.
It really
I
just looks
just
like
saw that. That's the first time I've ever seen it.
You took a really infected eye and just flipped them on their head really fast before it could settle another way.
And so I think our winner is someone Naginata 333.
Amazing.
Shoot us an email.
Super smart.
Yeah.
And please email events@emrap.org for your, what is the prize?
AirPods.
AirPods. So email those. We'll get those AirPods to you. Really cool image. Very rare diagnosis. I can't believe you've actually seen it. Billy hasn't even seen it.
It was the shift after the last one you had there. That's what happened.
Got it.
I want to say thank you for everyone inviting me to join. It was fun.
It was great having you. It was really fun. We had a great night.
It was, seriously, I just feel so honored to even be in the same space with all these amazing people. And thank you all so much for joining us. Our next Grand Rounds is going to be our Urgent Care Grand Rounds. That'll be June 6th, so stay tuned for that. And thanks everyone for joining.
Like, subscribe, and check your diapers. See ya.
See ya.